telehealth is interesting because it comes down to incentives again, right? So one of the things we're seeing is that these fee for service arms are essentially saying, "Hey, that was a really fun experiment. I did like telehealth. Boy, that was fun. But you know what? I'm bringing people back in to see them in the office. I have a mechanism for doing this. I have real estate I need to pay for. I have staff I need to pay for." And so the incentives aren't aligned. So it's bringing people in. That's one thing that's going on. The other thing that's going on is you're seeing states, because we haven't seen it at the federal level, to say, CMS to say, "Hey, we're going to continue to fund this," mostly because they don't have the money to do it. And we're seeing states start to step up. So you've seen Massachusetts and I think New York. I haven't seen another yet, but those two, Massachusetts being the most bold, essentially is going to backstop all the telehealth and say at least telehealth for behavioral health, and they're going to backstop all of those visits and keep those funded at the COVID rates. And I think don't you think there's going to be a big push on this to make sure this stays funded?
I hope so, but you talk about all these perverse incentives, and we've never talked about this, but I am Canadian, and I used to live in British Columbia. And while I was there most recently, which would have been like 2011 timeframe, the government was funding telehealth visits higher than in person to try and drive the behavior towards telehealth. And the minute they stopped doing that, everybody dropped telehealth visits. So there's like so many things going on here. It's not just funding, it's I think preference